No problem. Welcome. Thank you very much for a great presentation and a really interesting study. I'd just like to kick off by saying it feels to me like 91 points on the MHQ is still really pretty good hand function.
Mm-hmm.
What do you think about that? Do you think we're operating on people, or in your study were people operated on really quite early, or do you think it's just that the MHQ is not that sensitive again to the kind of problems that patients with Dupuytren's disease have?
Yeah, I agree that the score of 91 points is rather high. So patients with quite good hand function would still might be in need for treatment. But I think in our study we found only a few false negative cases, which means that the chance of missing patients who are actually in need of treatment are small. And there were actually rather, there were more patients who had a false positive result. So who were predicted to need treatment while they actually were not in need for treatment. So I think that might be a limitation. On the other hand, we think that for that reason, it's a rather safe method to implement because, maybe we invite a patient for clinical evaluation too soon, but I think it's much better than you invite patients too late because they already need a treatment, but they will still say, well, stay at home.
Mm-hmm.
We see you next year.
Mm-hmm. Anna, I wonder, do you have any thoughts from the patient's perspective about this kind of remote monitoring? Do you see this as a good thing, or would you rather be coming into a clinic and seeing a doctor?
If I were a Dupuytren's disease patient, you mean?
Yeah.
Yeah.
Sorry, I was asking Anna what she
Oh,
thought.
sorry.
Anna's our patient representative.
Mm-hmm.
I think if your Dupuytren's is not so bad, then remote consultation and reassurance is great. But if the patient is really starting to have problems or having a lot of pain, then you might have to go for a face-to-face.
Yeah, I completely agree. It should be, I think it should be an addition to current clinical practice. It might be, maybe it might give patients also a feeling of safety that they're being monitored. Also, maybe when a surgeon decided to, they say like, well, see you and when you have complaints again. I think that happens a lot. That's what I was trying to say with keep patients on the radar. With it's quite an easy method, I think, to keep patients on the radar instead of losing them out of sight. So I think, do you agree, Anna, with that?
Yeah, and I think patients will appreciate not being told to just go away and come back when it's bad, but to hear that, we'll keep an eye on you, and we'll jointly make the decision of when you need to come in and when we need to talk about surgery.
Yeah.
Okay, there's a question, in fact, two related questions, one from Charlie Eaton from Florida and one from Professor Sagan-Schmidt, both talking about measurements. Was there any correlation between the scores 15 months earlier and the degree of contracture when the patients were treated?
Good question. Well, we performed, as a first step, we performed an analysis on the longitudinal association between extension deficits and PROMs, because we needed to know whether it's actually the case before we could study this research question. And this was the case for both questionnaires. So both the URAM and the MHQ were longitudinally associated with extension deficits.
Okay, great. Jeremy.
Thanks. It was really interesting study. I enjoyed it a lot. I was interested in the ROC curves, and you talked about optimal cutoffs, and this kind of perhaps relates to what Dom was saying of the cutoff of 91. My understanding that there's some different ways to pick cutoffs on ROC curves, and I don't know if this is, I don't want to get too technical, but I was just curious whether that's something that you looked at, because particularly the MHQ pre-op curve looked like it might have had a couple of different candidate cutoff points, and I don't know if you discussed that as a team and looked at that.
Yeah, good question. We actually did together with Duke Brooks. We performed this analysis, and what there are multiple ways to determine the optimal cutoff value, because there's little evidence in literature what should be the optimal cutoff value. We decided to select this value on the highest sensitivity and specificity in our study. But for the MHQ, you're right that there could have been more potential cutoff values, and we find the highest specificity and sensitivity on the 91 points. But yeah, there was a little difference between other values. So that's a good comment on that.
Yeah, I think choosing cut points for continuous variables is always difficult, isn't it? Because you're trying to make something yes or no when actually it's it is by its very nature a scale.
Indeed.
Good. I don't think there are any more questions from the audience. Anna, do you have any more questions at all, or shall we let Bente be free from being a panelist?
I was just wondering whether the 91 score might also have to do with differences in the timing for surgery between different countries.
You mean that if we had selected another interval than the 15 months, then it would be different?
No, I mean that in the UK many times we say surgery is only indicated when you're at, say, 30 to 45 degrees contracture, but maybe in other countries you do it sooner.
I'm not sure if I understand your question correctly.
So Bente, I think what Anna's trying to say is that do you operate on earlier disease in the Netherlands than, for example, we do in the UK, or someone does maybe in Australia or Germany or somewhere like that? So how generalizable do you think your findings are?
Well, I think that, well, of course, I'm not a clinician yet, but I think that that doesn't differ that much between our country and, for example, the UK. There are, of course, protocols but I also think that it's really depending on the complaints of the patients. It's really patient specific still. But I don't have the feeling that it differs that very much from between your UK and the Netherlands, for example.
Thank you.
So your boss, Bente, Paul Verker, has chimed in to say he follows the same guidelines as in the UK. So
perfect.
he agrees with your answer. You'll be pleased to hear.
Thank you.
We've got one more question from Wolfgang Wack, which is what in clinical practice, how would you recommend the actual procedure is done? Do you give the patients the questionnaire and then ask them to do it, send it in every 6 months, or would you recommend maybe it's done, I don't know, by a computer, or how would you do that?
Well, ideally, it would be web-based, so by computer. So, for example, patients will be sent the questionnaire every 6 months, and they fill it in at home, and then it will be monitored regularly, and not having to go to the outpatient clinic. So ideally, it would reduce costs, but also be beneficial for patients to have the feeling that they are monitored and kept an eye on.
Great, thank you, Bente. Excellent presentation, generated a lot of thoughts and a lot of questions. Thank you very much for coming on and being a panelist and answering those. I'm afraid I'm going to send you back to being an attendee now, so apologies for that.
No problem.
Do stick around, everyone, for the end of the presentations tonight, because there will be a prize for the best presentation, which is being judged by a panel at home.